Good afternoon, everyone. I'm Haley McCalla, an ORISE Fellow appointed to CDC's Center for Preparedness and Response, Division of Emergency Operations. Thank you so much for joining us for today's EPIC webinar titled The Opioid Crisis. Today, we will hear from Dr. Sarah Bacon. If you do not wish for your participation to be recorded, please exit at this time. You can earn continuing education by completing this webinar. Instructions on how to earn continuing education can be found on our website, emergency.cdc.gov/EPIC. The course access code is EPIC 0327 with all letters capitalized. To repeat, the course access code to receive continuing education units is, in all caps, EPIC 0327. Today's webinar is interactive. To make a comment, click the chat button on your screen and then enter your thoughts. To ask a question, please use the Q&A button. The Q&A session will begin after our presenter has finished. Closed captioning is available for this webinar. The button to enable this function can be found either at the top or bottom of your screen. We are very fortunate today to have Dr. Bacon as our speaker. Dr. Bacon is the Program Director for Prevention for States and the Data-Driven Prevention Initiative. She's a practice-oriented prevention scientist with experience spanning the fields of law enforcement, academia, and public health. Across these disciplines and different domains, the common thread is her commitment to using data and science to make communities safer. Sarah began her time at CDC in 2010 in the Division of Violence Prevention, where she was the lead scientist for the National Centers of Excellence in Youth Violence Prevention, a strategic initiative for implementing and evaluating violence prevention strategies in high-burden communities. While much of her work focuses on evaluation, Sarah is also fully immersed in implementation science and has significant hands-on experience with the implementation realities that often challenge our scientific agendas. She moved to the Division of Unintentional Injury Prevention in 2015, where she leads the division's state-based opioid overdose prevention efforts. A key part of her role involves informing the development of CDC's scientific and programmatic directions for addressing opioid overdose. Sarah holds a Ph.D. in criminology, and prior to joining CDC, she spent 4 years on the faculty of the College of Criminology and Criminal Justice at Florida State University. Thank you so much for joining us today, Dr. Bacon. Please begin.
Thank you, Haley, and good afternoon, everyone. I am always really eager to connect with folks about the importance of this issue and the work we're doing here at CDC, along with a number of other federal partners, to address the evolving opioid epidemic. So I hope I'll share something useful with you today, and I look forward to some questions and conversations at the end of my presentation. We frequently hear and talk about the opioid overdose epidemic or crisis. It's in the media and it's in the national conversation enough that we're kind of used to hearing this language. But let's take a few minutes to look at the data and to really remember what this actually means in terms of how it's impacting our communities and our lives. So starting really from the big picture at the national level, take a look at this progression of heat maps. These show drug overdose mortality rates or deaths, with blue and green and the cooler colors indicating lower age-adjusted death rates, and the warmer colors indicate increasing and high rates of deaths from opioid overdose. So red indicating the highest rates. You can see from looking at this progression over time from 2000 through 2005, 10, and 16, that we moved from a lot of very cool spots in 2000 to more and more hot spots over time, culminating in a pretty red and orange map in 2016. This shows us the rapid acceleration of drug overdose deaths by county in a relatively short period of time. So we can see that the intensity of the problem exists not only in terms of the rate and the speed of growth, but also with respect to the absolute numbers themselves. In 2017, for example, there were over 70,200 drug overdose deaths, and opioids were involved in about 2/3 of those. If you're like me, numbers that large with respect to people are sort of difficult to wrap your head around. So here's another way to look at it and put it in perspective. As it currently stands, about 130 Americans die every day from an opioid overdose. That's 130 people every day. On the next slide, we'll unpack this data and these numbers a little bit more and look at which specific substances are driving these trends. From 1999 through 2017, almost 400,000 people died from an overdose involving an opioid, and that's whether you're talking about a prescription or an illicit opioid. When we look at across this time span, we see that there are three interrelated but also distinct waves or phases of the epidemic. So the first wave, which is depicted by this purple line, began with increased prescribing of opioids in the 1990s, with overdose deaths involving prescription opioids increasing since at least 1999. I'll note here that with respect to this wave, when I say prescription opioids, I'm talking about natural and semi-synthetic opioids, and I'm also talking about methadone. This is really where it all started, with a dramatic increase in the rate of prescribing, even though the amount of pain that Americans were reporting during this time frame remained unchanged. So we'll talk about that a bit more in a later slide when I share more about CDC's prevention efforts. You can see the second wave starting here roughly in 2010, where this yellow line shows the rapid increase in overdose deaths involving heroin. So in the face of continuing troubling rates with respect to prescription opioids, we're also seeing, in addition to that, a shift to significant increases from illicit opioids, and in this case with the second wave, particularly from heroin. Shortly thereafter, in 2013, this very dark blue or almost black line shows the precipitous increase in overdose deaths involving synthetic opioids. This is the third wave of the epidemic, and particularly implicated here are deaths from illicitly manufactured fentanyl. Over these three waves, you can see that there appears to be some leveling off of the first two, those for prescription opioids, including methadone, and for heroin. Of course, a lot of work remains to be done with respect to those substances, because while we are encouraged by the direction of these trends very recently, the absolute number and the burden here is still painfully high. But you can also see that we have not yet turned the trend or the tide with respect to this third wave of synthetic opioids. So a bit later in the presentation, I'll tell you a lot more about what CDC is doing on all of these fronts. First, though, on the next slide, I want to share one more dimension of the overall trends of this epidemic. And I show you these data to remind all of us that this isn't really just an opioid epidemic. This is a drug overdose epidemic. We are seeing increased evidence in some jurisdictions and from some data that deaths from things like cocaine and methamphetamines are also on the rise. Death rates from these drugs have more than doubled, and in some cases for specific substances have tripled. At times we see their use is connected with opioids, but that's not always the case. And so as we work our way through the opioid overdose prevention and response efforts, it's really important that we be forward-looking to ensure that we are also building the tools and resources we need to prevent misuse and overdose from other drugs. We talk a lot at CDC about fatal overdose events or overdose mortality. As our work with our partners unfolds in very applied settings, though, we remain very much in touch with the reality that these overdose deaths are one tragic outcome that represent the tip of an iceberg of other associated harms. Every one person who dies from an opioid overdose represents a preventable outcome for the 13 people who suffer with heroin addiction, for the 35 people who suffer with addiction to prescription opioids, and for the hundreds and thousands of Americans who report some other form of either misuse or exposure to opioids. Even beyond what is depicted in this graphic are the countless family members, friends, children, and communities that are so deeply wounded by the consequences of this overdose crisis. The reach is so extensive and ubiquitous that I imagine, unfortunately, everyone joining us today has been affected in some way or another by this crisis. It's very real for all of us. The impact of the opioid crisis can even be felt when we look at the overall US life expectancy. So this graphic shows us the impact of the 12 leading causes of death on life expectancy. And you can see in the sort of bottom panel here that opioid-involved poisoning decreased life expectancy by over 2 months in just the last 5 years, between 2000 and 2015. So I hope at this point to have convinced you all that this truly is a crisis and is truly a pressing issue of national importance. I'd like to now pivot to a more positive take on what we're doing about this and tell you about some of our efforts here at CDC. Our North Star is to prevent opioid overdose and deaths, and all of our work is captured in the 5 domains represented here on this slide. So I'm going to use the rest of my time to give you examples and illustrations of the work underway with respect to conducting surveillance and research, building state, local, and tribal capacity, supporting providers, health systems, and payers, partnering with public safety, and empowering consumers to make safe choices. I want to caveat my remarks by just reminding you that the examples and illustrations I'm going to share with you are intended to sort of convey the flavor and the spirit of the work that we're doing with respect to each of these domains. This is not a comprehensive catalog or inventory of all the work we have underway here at CDC and with our other partners, but I think it will give everyone a sense of our strategic directions and where our focus lies. First, I want to briefly mention we have funding and touch points in every state, plus DC and several US territories. The names and all of the official titles of the various funding mechanisms that we use may vary from state to state, and the focus of each of our funding mechanisms may differ slightly. But the main point that I really want to convey with this slide is that access to CDC resources and technical assistance and scientific expertise is available no matter where you live. Regardless of the funding status of your state or your community, our resources are available to you. So I'm not going to talk much more about funding because, again, that's just sort of the mechanism that we use to connect with partners to do the work. But I do want to quickly mention our current open funding opportunity, Overdose Data to Action. This is in an open application period right now. So states, territories, and certain eligible localities are hard at work on their applications to submit in early May. And we are really excited to see what work we can continue to do with our partners under a more streamlined and comprehensive award. As you saw on the previous slide, one of our strategic pillars is conducting surveillance. Better data means better prevention and better response. So this is really at the core of a lot of our opioid work. We partner with our recipients and other partners and stakeholders to ensure that we have the data systems, but also the data standards and infrastructure in place that's required to gather these data and to use these data in a meaningful way. So we focus on getting more timely and more specific non-fatal data. So for example, those are data that come to us largely from places like emergency departments or from our EMS and first responder partners. And then use those data to detect rapid shifts in either overdose patterns or substances that may be involved in overdoses. We also support our partners in ensuring that that information is then used and shared with the necessary partners who can act on it. So for example, that may include our harm reduction partners who may want to get word out in communities about changes in the lethality or the potency of the drug supply. It may mean communicating with our police and fire and first responder partners who may need to be prepared to respond to different levels of overdose events in the field. We also focus on getting more complete fatal overdose data to inform our continuing effort to understand risk factors and other variables that may either increase or mitigate the risk of overdose events. On the next slide, you'll see that we also do a lot of work that focuses on enhancing and maximizing the use of prescription drug monitoring programs, or PDMPs. They may be called PMP in your state. PDMPs align, of course, with our strategy of getting better, faster, and more timely data, but they also help us achieve the work of the second pillar or domain, which was building state, local, and tribal capacity to respond to the epidemic. PDMPs, very quickly, are state-run databases that collect patient-specific prescription information at the point of dispensing. PDMPs are among the most promising state-level interventions to improve opioid prescribing, but also to inform clinical practice and to protect those patients that may already be at heightened risk of opioid misuse, abuse, or overdose. PDMPs can help providers identify patients who may be misusing prescription opioids or other prescription drugs, and they can also provide public health authorities with timely information about prescribing and patient behaviors that contribute to the epidemic. In addition, states can use PDMP data to determine hotspots or geographic areas within a state that may be disproportionately affected by the epidemic and have higher rates of prescribing, and therefore target interventions in those areas. So things like academic detailing or other forms of clinician education and prescriber support. Given the promise that PDMPs hold to prevent opioid misuse, abuse, and overdose, we support our recipients as they implement strategies to improve the functionality of PDMPs and to scale up the use of PDMP data through inter- and intrastate interoperability. In addition to our direct funding, we work really hard to build and disseminate other actionable resources to support state, local, and tribal capacity. Here at CDC, we have the scientific capacity and the appetite to take a look at existing practices and see which of those have been subjected to really rigorous data-driven evaluation. We can then take a critical look at those evaluations to see what we should be highlighting or sharing with our applied partners. So this publication is one example of that work. It offers a really nice accessible list of what our partners can be doing that has been tested and has been shown to be effective. The evidence-based strategies that are captured in this kind of menu cover things like effective practices with respect to naloxone, which is a life-saving drug that reverses the effect of an overdose, and also things like best practices for medication-assisted treatment, or MAT, which is an evidence-based approach to opioid use disorder treatment that uses drugs like buprenorphine or methadone or naltrexone to help people manage their disease. A new frontier for us that we're now more explicitly exploring and supporting is the integration of state and local efforts. A lot of the resources that are required for effective opioid prevention and response exist at the state level. But we've also found that effective expressions of our prevention and response efforts are more likely to unfold at the local level. And we also see that localities are driving a lot of the innovation that we're anxious to subject to rigorous evaluation. So we want to get everyone connected and get everyone talking to each other. I also want to note here that this really goes beyond integration of state and local public health partners. They are, of course, essential, but we really need everyone at the table. We need to work across the spectrum of stakeholders, and our last several years of experience has brought us into communication and true partnership with a much broader and more diverse range of partners than who we worked with before. We need public health, of course, but we also need clinicians and care providers. We need law enforcement, first responders, legislators. We need our technology and IT infrastructure partners. We need harm reduction partners. We need the faith community. We need schools. Really, we need anyone and everyone who's part of these communities that are so affected by this epidemic. They can and should be a part of our prevention and response work. We know that this is much easier said than done, that there are a lot of bridges to build and common languages to discover in order to have this meaningful integration. But we think that's a worthwhile investment, and we're committed to supporting our partners in this area, both with respect to funds and with respect to technical assistance and insight. The final example I want to offer today in terms of how we are supporting increased capacity among our state, local, and tribal partners has to do with ensuring a systems-level approach to connecting individuals in need of care with the services that provide that care. At CDC, we are not engaged in the direct provision of care or treatment or service delivery. That's not really our lane, but we do have a responsibility to ensure that there is a bridge from the identification of risk to the mitigation of that risk. And people get really lost in our healthcare system. It can be really hard to navigate. And when withdrawal is coming on, it's really unrealistic for us to place the onus on the individual for finding the appropriate resources and getting connected to care. It's also unrealistic to place that burden on an individual's community of support and family and friends. We need a systems-level approach to ensuring that we are building those bridges and getting folks delivered to the care that they need. So linkages to care are those bridges that connect the work of public health with other agencies and the other partners that do provide that care. We embrace the philosophy that any door is the right door. So while we enthusiastically support linkage to evidence-based treatment for opioid use disorder, like medication-assisted treatment, for example, we also support other processes and systems that just ensure that our public health system and the doors that are playing a positive role in keeping people connected to some form of care may ultimately lead them to care specifically for their opioid use disorder. So these systems and solutions may simply be about establishing communication and protocols with other service partners, or maybe just about building the technology that supports and facilitates that communication from one system to another. Examples that we've seen so far of linkage to care include things like peer navigators, warm handoffs in emergency department settings, pre-arrest diversion from our law enforcement partners, and post-release linkages from incarceration settings, and community health workers. But we're also really excited to see what our partners have generated in terms of innovation in this space. The third strategic pillar that I mentioned is supporting providers and health systems in being a part of the solution. I mentioned earlier that the rapid increase in opioid prescribing started around 1999. The quadrupling of opioid prescribing was accompanied by a rapid increase in overdose deaths. From 1999 to 2017, almost 218,000 people died in the United States from overdose related specifically to prescription opioids. And opioid deaths involving prescription opioids were 5 times higher in 2017 than they were in 1999. Opioid prescribing hit its peak around 2012 with over 249 million opioid prescriptions written that year. That's enough for every American to have had their own bottle of pills. So we know that if overprescribing was a part of the problem to start with, then changing prescribing behavior can also be a part of the solution. In recognition of that fact, the CDC in March of 2016 published our guideline for prescribing opioids for chronic pain to help address the overdose crisis and prevent overdose deaths. These guidelines are intended to be for use in primary care settings for adults with chronic pain, and they are not intended to be used for patients with active cancer or in palliative or end-of-life care. But we know that well-intended physicians are the most common source of non-medical use of prescription opioids, whether through direct prescription or more likely, physicians are the initial source of a prescription for someone else that was then passed along. We call this the friends and family plan. And as you can see on this graphic, for every group of non-medical users of opioids, they most likely obtained those opioids either directly from a physician, as you can see here in the light purple bar for every age or for every frequency of non-medical use, or more likely from a friend or a family member, as shown on the turquoise bar. So on the next slide, you'll see that the guideline is intended to help put some parameters around what safe prescribing looks like. It provides recommendations to primary care providers about the appropriate prescribing of opioid pain medications to improve pain management and patient safety. There are 12 recommendations in the guideline, but 3 principles are key in driving each of these. The first is that non-opioid therapy is the preferred choice for chronic pain outside of end-of-life care. Second, when opioids are the appropriate choice, the lowest possible effective dosage should be prescribed. And third is that providers should exercise caution when prescribing opioids and monitor their patients very closely using the prescription drug monitoring program and other means of staying connected with their patients. Of course, providers should weigh both the risks and the benefits of prescribing prior to prescribing opioids for patients with chronic pain. We recognize at CDC that the guideline is not a one-size-fits-all approach, and it's important to note that CDC is not a regulatory agency, unlike, for example, the FDA. The recommendations in the guideline are voluntary. They are not prescriptive standards. It's practical information that's intended to provide recommendations about appropriate prescribing of opioid pain medications to improve both pain management and patient safety. We understand and are committed to ensuring that prescribers and clinicians have the tools and resources they need to implement the guideline as intended. And research suggests that after clinical guidelines are published, there's moderate knowledge of recommendations and fairly low levels of adoption, unless we also offer intensive approaches to communicate the recommendation and guide providers through that implementation. So in that spirit of ensuring awareness and appropriate application of our guideline, we offer several tools and resources to accompany the guideline itself. First, we know that we need to distill the information. So that means translating the guidance and communicating it in user-friendly language and tools. We also know that we need to support capacity. So we need to build skills through trainings for organizations and providers who are expected to use the guidance. And finally, we need to support the delivery of the strategies, and in particular, implement activities and evaluate actions for further improvement. In our case, we're achieving this work through our relationships with health systems and insurers. So our approach is really guided by 4 pillars to ensure appropriate and responsible implementation of our guideline. We're doing that translation and communication of the key recommendations within the guideline. We're doing extensive clinical education, training, and outreach. We're working with health system strategies and interventions that enhance the implementation of the recommendations at the point of care, and offering insurer interventions that support implementation of the recommendation through reimbursement and pharmacy benefit management techniques. Evidence thus far suggests that the guideline has been effective in changing prescribing behavior. We've seen declines in high-rate prescribing, so that's people on very high doses of opioids, declines in patients with overlapping opioid and benzodiazepine prescriptions, which is a risk factor for overdose, and we've seen a decline in the overall number of opioid prescriptions. Again, we're committed to ensuring that our guideline is applied as intended and that prescribers and clinicians have all of the tools they need to make the right choice for their patients. Our 4th strategic direction has to do with partnering with public safety. There are a lot of examples of how this work is unfolding at the federal level and also how we're supporting it at the state and local level. The one I want to draw your attention to today is our opioid response strategy, which began in 2015 and now covers 24 states. This is a partnership between CDC and 11 high-intensity drug trafficking areas, or HIDAs. The HIDAs are a grant program within the White House Office of National Drug Control Policy, and their aim is to disrupt and dismantle drug trafficking organizations. They've connected with us, though, at CDC to be the public health arm and to complement their public safety approach. So together, we're working toward the mission of helping communities reduce fatal and non-fatal opioid overdoses by developing and sharing information about heroin, fentanyl, and other opioids across agencies and disciplines. So that's really just about data sharing and staying connected with each other about what our various lenses on the epidemic are telling us. And also by offering evidence-based intervention strategies. So more specifically, there are 4 goals that direct our collaboration with the HIDAs for the opioid response strategy. First is to create and coordinate data sharing that allows public health, law enforcement, and others to respond quickly and to effectively address opioid overdose incidents and trends. Second is to develop and support strategic evidence-based responses that generate immediate reductions in the number of overdose-related fatalities. Third is to promote and support efforts to prevent or reduce opioid misuse. And finally, to promote the active engagement of local communities in the discussion, planning, and implementation of all of the opioid response strategy goals and activities. Our last strategic direction is to empower consumers to make safe choices. And this is, I think, the perfect place to end my talk and come full circle back to the very real people and the very real lives that are affected by this epidemic. So I'm going to show you now a collection of vignettes from our RX awareness campaign, which is intended to help everyone understand the risks associated with opioids and empower people to have important conversations with their healthcare providers. If you want to see more of these videos, they're available, and you can check out the entire series of RX awareness vignettes on our website at www.cdc.gov/RX awareness, and that link will also appear at the end of this vignette that we'll play for you now.
Everybody knows somebody who is struggling with opioids.
I got my wisdom teeth taken out. I must have gotten a 30-day script. I took them all in 3 days.
My son was 20 years old when he was prescribed opioids.
Nothing mattered more than getting my fix.
My son Steve did not want to die, but his prescription opioids killed him.
And with that, I will close the formal part of the presentation, and we can open up for questions and conversation.
Thank you so much, Dr. Bacon, for a wonderful presentation. Jonathan, do we have any questions from our Q&A?
We have quite a few questions, and this, perhaps as expected, has been an issue that arises that brings out some concern in people on multiple sides of this issue. So we're focusing on the more general questions here. If people have specific questions, you can send them to EPIC at cdc.gov, and we can pass those questions on to the presenters. So the first question is from Awa Kinney, and the question is, what are some ways that community-level prevention programs can use PDMP/PMP data other than prescriber pharmacy clinical prevention efforts?
We talk a lot about the PDMP data as either a clinical decision-making support tool, which I think is what you're saying you know about and want to hear about other applications. So the second way we talk about the power and influence of PDMP data is as a public health surveillance tool. And what I mean by that is simply saying that the PDMP data can tell us where you have high rates of prescriptions going out into the communities. So it doesn't even have to be patient-specific, and it doesn't even have to be prescriber-specific. You can look at the county level, for example, and see where there are aberrant rates of prescribing that might suggest the need to generate some proactive prevention and response resources in that particular community. If there are counties or communities within your state where you're seeing very high rates of opioid prescribing, it may mean that you want to connect with your harm reduction coalitions to ensure that the affected communities have access to naloxone, which again is that life-saving drug that reverses the effect of an opioid. It may mean that you want to do some outreach through other community partners, faith communities, schools, et cetera, in terms of educating consumers about the risks of consuming opioids in combination with other drugs. And also ensuring that members of the community are aware of treatment resources that may be available for folks that may be at heightened risk and may be experiencing suffering with addiction and might be interested in getting connected with care. We know that there are care resources available, but a lot of the folks who need treatment services and care are not getting it. So that's one of the areas where we're really interested in putting some strategic effort and attention. And I think the PDMP data are an important way for us to decide which communities that should be a priority in.
Okay, and the next question comes from Daniel Seltzer, who asks, does CDC have any recommendations on the use of opioids in the acute care hospital-based setting?
At this point, we do not have formal recommendations associated with opioid use in acute care settings. We are working with a number of partners who have generated recommendations for these settings, and to offer not necessarily a formal guideline, but some benchmarks associated with what safe and appropriate prescribing may look like in those settings. So at this time, I think we could direct you to some resources generated by other partners, but stay tuned for something specifically from the CDC on that front.
Next question is from Al Romanowski, who asks, how do you distinguish between accidental overdoses versus suicide attempts?
That's a great question, and it's a really tough question. It's part of what some of our data enhancement efforts is intended to get at. I mentioned our efforts to improve the data around fatal overdose events. Part of that is through the State Unintentional Drug Overdose Reporting System, or SUDRS. And SUDRS gathers really rich data that helps us understand more of the context and the circumstances that surrounded a fatal overdose event. Of course, if it's a non-fatal event, we have a patient to talk with to understand whether there was intent driving the event. For fatal events, in the absence of a note, it's very difficult to make that determination, but there are frequently some contextual clues or variables that at the scene of the event. So we want to build the data systems that are capable of gathering that information so that it's available to our medical examiner and coroner partners, to law enforcement and first responder partners, to our partners in mental and behavioral health and substance abuse prevention. But it's always going to be a situation that we will have to piece together. And a lot of our efforts that are directed at improving the richness of our fatal overdose data will begin to get at that question.
Okay, thank you. We've received 2 requests here for a future version of this webinar in Spanish. So I can tell you that we will give this some serious discussion. I can't commit to anything, but I can certainly can appreciate the fact that there are people who are interested in this information. The next question comes from Johnny Andia, who says, linkage to care is important to reduce, control the opioid, heroin, and cocaine epidemic. Do we have any drug treatment spots for all the substance users that will need real treatment for their opioid problem? I believe the question he's asking is are there places to go to?
Yes.
People should focus on.
Yes, there are. And so a lot of our efforts are intended to address exactly that question and making sure that folks are aware of what the actual real available resources are in their communities. So for example, our partners at SAMHSA and at NIDA, the National Institutes for Drug Abuse, have worked on some fantastic resources that convey real-time availability of treatment spaces, whether it's inpatient or outpatient treatment availability. And so a lot of the work that we're supporting our partners to engage in is making sure that those resources are available, that folks are aware of them and are using them, and to do the quality improvement to make sure they're as usable and accessible as possible. One of the challenges, again, is ensuring that that message is getting to the right person. So in addition to ensuring that people suffering with addiction themselves have access to and awareness of those resources, we also really want to focus on ensuring that our health systems and emergency department docs and paramedics, but also the friends and family of people suffering with addiction or just at risk of overdose, are aware of those resources as well. So the linkage to care conversation has been taking shape for several years now, but this is really our first sort of formal foray into this space to define what those linkages look like, what are the resources that people should be linked to, and how can we ensure that we have the strategies and the communication across partners in place to make people aware of resources.
Thank you. The next question comes from Cheryl Nelson. Have you seen any decrease in drug deaths associated with any particular data group which has been reported?
I'm not exactly sure what is meant by data group. I will say, I think you could define that any number of ways. If we're talking about geographic differences, yes, we have absolutely seen differences in the rates of decline by geography. A lot of that has to do with the availability of the drug supply in different parts of the country and the lethality associated with, again, for example, that illicitly manufactured fentanyl, which is really volatile and unpredictable in terms of the potency and lethality associated with that. So I think it really depends on whether you're looking across geography, across age groups. We have seen some unfortunate increases among younger populations. So yes, we are being careful to pay attention to different rates of growth or hopefully declines across different segments of the population.
Thank you. We are seeing a few questions here that are more of a clinical nature. Questions about sort of how to define chronic pain, or questions about alternative treatments for pain besides opioid use. And what I would have to say to that is that it's kind of outside of the scope of this presentation, but if anybody has a particular question, you can send it to EPIC, that's epic@cdc.gov, and we will pass those questions on, even if we can't answer them in this format. So a question from Richard DeGroot, who asks, can the PMP data be used across state lines?
Yes, that's something that we're working hard to support our state partners to improve and expand and enhance. PDMPs are all state level authorized entities, and so a lot of the sharing across state lines is determined by each state's specific policy and legislative status. So each state may look a little bit different, but over the last 2 or 3 years, we've seen really dramatic and very encouraging growth with respect to what we call interstate data sharing, both with respect to developing the technological capacity to share data across state lines, the technology to integrate those data into the typical clinician workflow so that it's just part of an electronic health record or whatever they're looking at for a patient at the point of care. And we've also seen tremendous growth and progress, we think, with respect to sort of the political and cultural will to do that, to share data with other states or other jurisdictions to ensure that clinicians have access to a complete picture of the prescribing history of the patient who's sitting in front of them at that moment.
Thank you. We got a question from one person who asks if you can repeat what you mentioned pertaining to the work that is done by collaborating with HIDTA.
Yes, the HIDAs. So the high intensity drug trafficking areas are a grant program operated through the White House's Office of National Drug Control Policy. Their mission is really more to do with interdiction and stopping the drug supply. But in the course of doing their work, they recognized that they were encountering a lot of what are ultimately public health questions and challenges. And on the basis of that, we're collaborating in the form of the opioid response strategy, which is now impacting or unfolding in 24 states. And it's really sort of the combination of data sharing and awareness. So, for example, what do law enforcement data tell us that health data don't necessarily tell us? Do they paint a different picture of what the epidemic might look like in a specific jurisdiction? And vice versa, how can our public health data be used to complement the understanding driven by law enforcement data? So the data sharing piece is the first part of that. But then in that spirit of using data to inform action, we take a critical look at what the data tell us and use that to inform a combination of strategies that really sit at that intersection of public health and public safety. So not just for prosecution, arrest, et cetera, but really to understand how law enforcement and first responder partners can be part of an arm of implementing public health solutions and strategies. One of my personal interests right now in understanding better is pre-arrest diversion. So for example, if a law enforcement officer encounters an individual who has broken a law, but is perhaps more of a status offense or a misdemeanor, and they can see that that person is in need of treatment services, they may opt to connect with a treatment provider or a harm reduction partner to connect that person with care and services, rather than starting the process of the criminal justice response that they may typically have done before. So that's just one example. There are others, but we're very excited about this collaboration in particular because so often it is our law enforcement, public safety, and first responder partners that are first on the scene of any overdose event.
Great, thank you. I'm going to read a comment. Normally we're reading questions, but it's one comment that we thought really stood out. It was from Jennifer Peterson, who said that we would add libraries to your list of partners. And that's because I understand libraries, and we've had some interaction with the Public Library Association, actually wind up being involved in the opioid response.
Jennifer, thank you. I really appreciate that comment. And it's actually, we have heard that from other partners as well, that libraries are very much a part of a community, and in certain communities are very much the lifeblood of a community. And as I said, our linkage to care philosophy is that any door is the right door. So anywhere that provides a venue or a setting for us to connect with folks who are in need of some sort of treatment or services is absolutely an appropriate venue for us to then get them connected with a system of care and the services that they need. So thank you for that. And I will actually make sure that that language is reflected in our future conversations.
I'm going to read to you a question from Jennifer Austin. The question is, who do we contact for more treatment options being available in our communities? The waiting lists are frightening, inpatient, outpatient, and MAT. People with addiction need help now rather than months from now.
People with addiction need help right now. And there's a lot of evidence that shows us that, for example, if someone is in the emergency department for either an overdose event or actually any other event, but if it's clear that they are at risk for overdose, that's really the most important opportunity for us to seize and get them started on buprenorphine, for example, or started on medication-assisted treatment. The closer and closer someone gets to experiencing the system, the effects of withdrawal, the more likely they are to return to problematic use of opioids. So we very much appreciate the spirit of that question, and that's exactly what our linkage to care work is intended to address. In your specific community, I would recommend a couple of starting places. First would be your local, whether it's city or county, public health department. They should be connected with whatever behavioral or mental health services are available in your community to get folks connected with treatment resources that are available. There are also state level resources, your state level substance abuse authority, for example, who should have an inventory or catalog of what the treatment resources are that are available. And we are also happy to help you make some noise if you find that those treatment resources are inadequate. So we would love to hear from you. If those resources don't get you exactly what you need, we need to hear about that, because in our work to link people to care, we also have a responsibility to ensure that the care is available to them.
Great, thank you. The next question is coming from Alicia, A-L-I-C-A. In our area in Southeast Missouri, people that are not getting treatment because of a lack of insurance, and also there's a small amount of treatment facilities in the area, is what she's trying to say. So there's, I guess, limited access to treatment. Can you address what options people have in that situation?
We're working really hard to develop better and more options for you than the ones I can identify here today, because we recognize that that is a deficit and something that needs to be addressed. Again, I will just clarify, CDC's role is not in terms of generating direct treatment services or provision of services. So this is really a question that could be more fully and richly addressed by my colleagues at SAMHSA, for example, or with your local substance abuse prevention and mental health and behavioral health partners. Having said that, again, our commitment is to linkage to care, and we recognize, particularly in rural and frontier populations, it's a big challenge. Even if there is availability of services, it's tough to get folks to those services. So we are investing in various forms of mobile service delivery as a form of connection to care. Sometimes people just literally need a ride. It's that simple and that sort of logistically straightforward, is that people just need a ride to get their MAT or to get the treatment services that they need. We're supporting those sort of efforts. And we're also really interested in exploring the options associated with telemedicine and telehealth. There are certain restrictions around that regarding the provision of medication-assisted treatment and prescriptions, but we're very aggressively pursuing some flexibility and options associated with telemedicine to ensure that everyone across the state has access to the resources they need.
Okay. The next question comes from an anonymous attendee, and it's this: are there any states tracking if overdoses are occurring with just opioids, or are they combined with others like stimulants or benzodiazepines? They're saying it seems like frequently a combination of drugs, and wondering if patients on these combinations would be at high risk.
Yes, in fact, most states are tracking those data. 33 of them are doing it through the assistance of our Enhanced Surveillance of Opioid Overdose in States program. And again, through that suitors system that I mentioned earlier, drug specificity and toxicology data are requested and usually reported. There are limitations associated with that, particularly with respect to delineating which opioids or which specific substances are in a decedent's system. Sometimes it's simply a matter of having access to the toxicology and drug testing equipment necessary to make that determination. And sometimes it's a matter of public health and clinical chemistry keeping up with illicit chemistry and new drug formulations that are emerging and having the capacity to detect those. More specifically to your question, though, regarding use with other non-opioid substances, this is absolutely an important area for focus. I mentioned briefly earlier that combination of opioids with benzodiazepines, for example, is particularly problematic and does dramatically increase the risk of an overdose event. So we pay very careful attention to that. But again, I mentioned that sort of new frontier and the reality that this is not just an opioid overdose epidemic, this is really a drug overdose epidemic, because exactly the data you're asking about are how we know that we are also looking at cocaine, psychostimulants, methamphetamine, sort of co-occurring epidemics. Sometimes those drugs are used in combination with opioids, sometimes on their own. But we are using data and ensuring that all states have the infrastructure, technology, and equipment and resources available to do that level of drug specificity testing.
Thank you. We've received a couple of questions about faith-based organizations and how they can be part of this, or if they can be a resource for addicts. Can you comment on that?
Yes, we have a lot of really energized and fantastic conversations with our faith-based community partners. To me, this is taking a trusted resource and point of conversation and connection in any given community and ensuring that those partners who already are part of a community and have earned the trust of community members have the tools and resources that they need to take care of their community, of their faith-based community. So with respect to what I've talked about today, I view the faith community very much as one of those sort of points of entry for linkage to care. It's a safe haven and hopefully one of the communities where we don't struggle with the stigma as much as we do in some other settings that are attached both with opioid use disorder, but also with some of the treatment options available to folks. So a lot of our work supporting state and local integration will necessarily involve the faith community as messengers and communicators and people that we need to equip with the resources to get folks connected to care.
Thank you. And one more question. It's probably appropriate to close this off with this question. It's something you and I discussed earlier. Peggy asked, targeting physicians simply makes them not prescribe. How do we encourage physicians to treat the patients that require the opioids?
Yes, that's a really important question and one that we pay a lot of attention to here. And, you know, I think the language Peggy is telling of targeting physicians, the guidelines are intended as a resource and a tool and something that should make patient care easier and more simple for clinicians. We do understand that at times, if you don't then provide the alternatives and the resources, that physicians have opted to simply stop treating people that are already on high morphine or high morphine milligram equivalents of opioids and recognize some of the problematic consequences that have come with that. That's why we are so committed to and working really hard to make sure that in addition to the guideline, physicians and clinicians have access to everything else they need to continue offering appropriate care to any patient, even while staying in accordance with the guideline. So we've offered a lot of training, for example, with respect to tapering and how to safely get dosages down while still effectively managing pain, but moving toward a safer level for patients. We also are doing a lot of work exploring other effective forms of pain management, so non-opioid and sometimes even non-pharmacologic approaches to pain management so that patients can get the pain management that they need and deserve, but can also be assisted in moving toward safer levels of opioid use. So thank you for that question.
This will now close our Q&A session. I just want to thank Dr. Bacon again for her time, and thank y'all so much for participating with your comments and your questions. If we didn't get to your question, please email it to epic@cdc.gov, and we're happy to forward that to Dr. Bacon. Today's presentation has been recorded, and you can earn continuing education for your participation. Please follow the instructions found on emergency.cdc.gov/epic. The course access code is EPIC0327 with all letters capitalized. Thank you again, everyone. Goodbye.